Calra. Mr. Shipley, you have 5 minutes.
Thank you so much, Madam Chair, Senators. My name is David Shipley, and I'm the CEO of Beauceron Security. We're focused on the human side of cybersecurity, and our mission is to help people make good choices about technology so they can reduce their risk and thrive in a digital world. We work with more than 1,500 clients, including some of Canada's largest banks, telecommunications, and public institutions, including hospital systems. I want to start by being clear that I support the goals of this legislation and I believe strongly in the need for digitally enabled healthcare for Canadians. Ending vendor data lock is long overdue. But even if we accomplish that goal, if we don't have a clear view of the growing risks to healthcare data and systems, the core objectives of this legislation will not materialize in the way we all clearly need it to. We need to talk about what happens when the more connected systems we're talking about get hit. Iran-linked threat actors have been systematically targeting healthcare infrastructure across North America. Canada's own communications security establishment co-signed a joint advisory with the FBI, CISA, and NSA, warning that Iranian actors have been conducting brute force and MFA push bombing attacks against healthcare organizations since October 2023. Earlier this year, an Iran-linked group encrypted an entire U.S. healthcare provider's network in under 3 hours. A separate Iranian attack wiped out more than 80,000 devices at medical device maker Stryker. Canada's domestic record is no better. Life Labs in 2019, 15 million medical records exposed. Newfoundland and Labrador's health system offline in 2021 due to a Russian-based ransomware attack. 5 Southwestern Ontario hospitals in 2023 and 5.6 million patient visits compromised. In 2020, ransomware hit the University of Vermont Health Network, the worst U.S. healthcare cyber attack that year. Within minutes, the hospital lost access to pharmacy, laboratory, pathology, and radiology systems. Individualized chemotherapy plan templates, the records telling staff which drugs to administer in what doses, were gone. Cancer patients had treatments delayed. Some waited weeks for biopsy results. Recovery cost was over $65 million and required help from the Vermont National Guard. That is what inadequately secured centralized health IT looks like when it fails. This committee should assume it will fail again and with more frequency, given the increased capability of threat actors thanks to the proliferation of AI as weapons of mass cyber disruption. And here is the hard truth about why we're still having this conversation. Canada doesn't act like a nation state when it comes to cybersecurity. When Parliament had the opportunity to designate healthcare as critical national infrastructure in cybersecurity legislation, it blinked. Jurisdictional concerns between Ottawa and the provinces got in the way. Healthcare is provincial, fine, but ransomware operators in Moscow, Pyongyang, and Tehran don't care. The Iranian hackers who encrypted that hospital network in the US will not pause to consider division of powers. Nation states and transnational criminals do not care about our 44-year-old Constitution and how it failed to envision the digital world we have to live in today. We should care. This committee can start fixing that today in a meaningful way by taking the concept of ending vendor lock further by reducing the inherent vulnerability of centralized systems. I have 3 recommendations. The first is to support both centralized record systems, today's model, and decentralized client-held record systems, which are the future. Let me be clear about where I stand. Healthcare institutions are not psychologically ready for a fully decentralized patient record model, and I completely accept that. But let's be honest about the trade-offs. Centralized systems can continue, but we go in clear-eyed that if security safeguards fail, the consequences will be severe and the blast radius will be wide. What we cannot do is build more centralization without simultaneously building an exit ramp, a patient-held record model that means the next breach doesn't take down care for an entire province. Start planning for that future now. Bill-S5 or its accompanying regulations should include provisions and a timeline for patient-held decentralized record storage. Keith Lawson, the Chief Information Security Officer at London Health Sciences, has submitted a brief to this committee laying out how it could work, and I support that. And what's important to note is an attacker who compromises a centralized repository gets millions of records. Someone compromising just one patient gets one record. And when a centralized hospital system goes down, a patient who holds their own records can still receive good care. That ability would have been invaluable during the 2020 University of Vermont attack or the attack on Newfoundland and Ontario's hospitals. The three recommendations, just to recap. Number one, be explicit in a mandate to allow for patients to hold their own records on their own smartphone, for example, which in the event of attack would allow for continuity of care and for the ability to recover, which is going to happen. The second recommendation is a pan-Canadian national cybersecurity standard for centralized patient healthcare systems to be supervised by the Canadian Centre for Cybersecurity, with some incentives, but also potentially penalties to provinces to invest in this area. If we don't start making more dedicated effort to this, it will always be bottom of the list given the political priorities around doctors, nurses, allied healthcare, or facilities. And then the third is actually getting the center to be resourced, to be actively involved, and not voluntarily asked, but actively involved and recapping key lessons learned. I had a lot of CISOs for hospitals calling me in 2021 wanting to know what was going on in Newfoundland because they had no idea if there was something they should be doing to batten down the hatches.